All right, Scott Becker, thanks for having us.
Thank you for having me.
No, really appreciate it. We're going to talk about innovation. So, I mean, you're Scott Becker, right?
Yes.
You're my daily Wall Street Journal in healthcare.
Thank you. We try to be. It's exactly what we try to be, is the core, concise news of the space.
Yep.
So people can follow it, know what's going on. Get it. It's exactly what we talk about. It's being the Wall Street Journal of what we do, getting the business side of what's going on, seeing what's happening, seeing what trends are and so forth. So thank you.
And I love the segmentation, right? That topical, right? It's very helpful, and we've enjoyed coming to the shows. And this new format's been so much fun to really meet people and talk about, like, hey, what are you doing? We had COVID. That's created a silver lining in so many regards of, like, you take telemedicine. Why were we going to take 5 years to get that done? Well, because that's what we do in healthcare. And then, until your back's against the wall and you got to get it done. So my first question for you is just like, what are you excited about with innovation as a backdrop, AI, machine learning, all the buzzwords we all love, but what are you excited about?
Sure. So thank you. There's a couple things that we think about and talk about all the time. One of them that you mentioned, and you mentioned it, sort of this concept of backs against the wall.
Yep.
And when you talk about other health systems, and I have a different take on our health system. I think our health system is overall remarkable.
Yep.
And you have to remember that we take care of 330 million people, the third most in the entire world after China and India.
Yep.
At the same time, it's remarkable, but it's challenged. So when I look at things that I'm excited about, when I talk to the transformation they're making in India on healthcare, I'm excited. Not that we want to exactly be like India, because that's an impossible challenge of 1 billion people plus.
Yeah.
But what they're doing right, which is something we have to move towards doing right, is this transformation to more of a preventive model.
Yeah.
And it's been, you talk about backs against the wall, it's been forced in India, it's been forced in China in a very draconian way, because they have no choice.
Yeah.
They don't have nearly the provider to patient ratio that we have.
Yeah.
We have a much better provider to patient ratio than almost any place in the world.
Yeah.
But we're also used to great convenience, all the beauty and luxuries of American life.
Yeah.
And what I'm excited about is keeping that strength, but greatly strengthening our preventive efforts. And it's a work in process. It's not just a digital work.
Yeah.
It's not just an AI work. It's an entire mindset change to moving towards a preventive mindset on everything.
Yeah.
And they have to do it in India, because if they don't do it in India, they have too many people that end up sick.
Right.
And if you end up sick or getting caught with, colon cancer, getting caught with whatever it is, way later than you could help, and they just don't have the resources.
But since the cultural backdrop is so different in those cultures versus ours, how do you take those lessons learned in China, India, but the American backdrop is going to be more of a democratic, structure. So, can you fuse those together, and can you get Americans to not eat cheeseburgers all the time?
Well, and this is a different part of it. One of the unspoken issues you just mentioned is, American obesity is a big part of the problem.
Right.
And I don't know that we as a health system can do that much about that. We could do as many PSA ads as we want.
Yeah.
We could certainly do things by, like, when I see high schools or grade schools or elementary schools getting rid of gym class, I think we're doing a horrible disservice. Because as you know, as we get older, we understand this mix of physical and mental health.
Yeah.
People say health is wealth, and as a kid, we take that for granted. We don't understand it. But we've got to build in those habits that physical and mental health is just critical for our entire lives.
Yeah.
I do think, I don't know if we'll get there on obesity and personal habits. I just don't know.
Yeah.
All of us struggle with that. It's a daily challenge for most of us to struggle with it. What I do know is a system, we'll have no choice. We basically have no choice. You'll get to a tipping point where, with the growth of the population, the aging of the population, you have to push yourself towards preventive medicine, and it's going to be preventive wellness checks, a lot of preventive things, preventive screenings. In India, they do it with handheld scanning devices.
That's right.
Here, we do it with billion-dollar scanning devices. It's just, or multi-million-dollar. There's a way to get there where you could blend. When I look at I will take our health system over that of China or India, and our problems over China and India, just because we're serving a fourth of the people, a fifth of the people. and we do a remarkable job of it. You have to remember, we're the third largest in the world.
Right.
At the same time, we have to move much harder and much more aggressive on this preventive effort on this side of the game. And it's something they're doing better and in a more authoritarian way in China and India, but that we need to do.
So I got a question for you with your legal mind in this So there are devices like ultrasounds that you can pretty soon buy over the counter and do preventive screening. But then we got the FDA, and there's certain things that the FDA serves its purpose, but many of us believe it still takes too long on certain innovations. Maybe they do clinical trials faster. Like, is there opportunity there to take some of those innovations? I can now do 70 use cases. Like, why don't you just let me do that? I'm still going to have a doc.
Yeah.
Anything like that?
It's a great question. When I think of the regulatory challenges, I think some of the FDA, I don't think the FDA is nearly as bad as it was 10 years ago.
Yeah.
And plus or minus, in the last administration, they did a lot to streamline things.
Yep.
And what you see from President Biden, not reversing some of those things. Because I think the FDA has gotten better over the last period of time, the last 10 years or so. The flip side is CMS, the reimbursement people, at the payers, at the federal government, are still playing a very challenging game.
Yep.
Like they are slow, for example, to make telehealth permanent. But we sort of know we need telehealth because it's just from a simple leverage supply demand, be able to get people care where they need it with a lot more convenience, a lot easier.
Yep.
So those kinds of things. Hospital at home is again not allowed, really, not fully. And we sort of got to get back to those kinds of things that will much better allow us to leverage our supply of physicians, our supply of PAs, our supply of advanced practitioners, and so forth. So when I think about this, I break down the FDA and CMS and Medicare and Medicaid into two different buckets. And I think, and Medicare, to their credit, they are trying hard. And they're trying to be careful of our purse strings. But at the same time, there are certain innovations. When I talk to people about population health, I talk to people about making transformation, a lot of the challenges, if they can't get paid for it, it ends up being just a very difficult thing to do. And so we've got to figure out how to cut fraud while allowing some of these things where there's concerns about fraud.
Yeah.
But I know
No. Well, you're teeing up my next question that we were chatting, you and I, earlier about pop health. And, we've been talking about pop health and value-based care, right, for 2 decades now. Yeah. So, is there an opportunity, because there's a groundswell of people wanting to innovate. Some of it we have to do because the Great Resignation and things like that. What's your take on it? It seems to me pop health has got to be more of a light switch.
Yes,
right.
It's a complicated issue. I mean, it's a complicated issue. I mean, on one hand, you had a lot of systems see people that were taking Medicare Advantage or taking value-based care during the pandemic make a ton of money, and they made it for the wrong reason.
Yeah.
They made it because care stopped being given. You didn't do surgical procedures, so everyone was taking capitation cleaned up. So you got some of the wrong reasons, but it motivated everybody to say, we really have to be in population health and value-based care.
Yeah.
Now you've got this next transition, which is, you mentioned it, the Great Resignation. 100,000 nurses resigned last year, which is a record number of resignations.
Big number.
And when you look at the situation, these are the kind of things that are going to lead us towards preventive care, people practicing at the top of their license, but more towards preventive care and population health is we just don't have the bodies to provide the care that we once did.
Yeah.
I mean, we don't have enough residency spots. We don't have enough workers in all settings, from people assisting in a medical office to practitioners to nurses to at every level. We're short of people. We used to solve a lot of that through a great job of encouraging immigration. Somehow or another, we've lost a little bit of our way in terms of encouraging immigration and the amount we need to solve some of our own problems.
Yeah,
I mean, aside from, and not from a red-blue perspective, immigration's always been the lifeblood, or one of the key lifebloods of our country.
Absolutely.
And it's certainly been one of the lifebloods of medicine. If you look at medicine in rural communities, but for doctors that have immigrated, we would not have rural health care in a lot of our places. So thank God for our immigrant population. But more to the point, on population health, preventive medicine, the great shortages we have are going to force us in that direction,
Yeah.
and it's trying to keep the greatness of the American health system while embracing some of the things that China and India are doing
Yeah.
to take care of 1 billion plus people.
Yeah.
I mean, we need to embrace some of those efforts. We will have no choice.
Yeah, absolutely. But again, with your legal hat on, regulatory sometimes just is too thick. It gets in the way. You talk to doctors and they're like, I just want to see more patients, right? How many of them say that? They're still at the terminal
Yes.
checking so many
Yes.
boxes that it's not moving the needle necessarily on
Well-
cost and quality. Can we innovate legal and regulatory?
Probably. I mean, you've got so many challenges, but I think you've got, you absolutely, I mean, people will talk about the EMR still 10, 15 years later. We're never going away from the EMR. It's been such
Right.
a huge godsend in so many ways,
Yeah.
but it does cost so much friction for doctors, for
Yeah.
nurses, for practitioners. It still does. And you've
And
got more and more solutions.
There's a lot of burnout associated with
So
it.
much burnout associated with,
Yeah.
but we're not going away from it.
Yeah.
Because I mean, imagine going back to a paper record where you're at one provider and they have no idea what the other provider has in their paper record.
Yeah.
So we're never going back to anything but the electronic
Sure.
health record. But all these things need lots and lots of improvement and fine tuning. I do get concerned with the workforce being overwhelmed at every level.
Yeah.
That even when you talk about coders in Poland, Ukraine, the other side of the world,
Yeah,
we don't have enough coders. I mean, just
Oh, yeah.
let alone,
That's a
let alone
massive
in the whole world, let alone in our country or any place. And we access a ton of it overseas, thank goodness. But we have like all these things that should be getting solved are a little bit slow in getting solved. So there's just not the bodies to solve them. I
Yeah.
mean, it's not just funding. Venture capital funds that will throw, tens of millions of dollars at people that don't even know how to use that money because
Yeah.
they can't put it to work fast enough.
Yeah,
So
absolutely.
there's not enough resources to put it into.
Yeah.
And so they're fascinating challenges. I do think, I'm optimistic that we'll blend some of the preventive stuff
Yeah.
with some of the care that we give now, which is at the end of the day, magnificent, challenging. We've got
Yeah.
problems, but overall magnificent.
Yeah.
I do think on the legal and regulatory side, I think there are challenges there. I think some of the regulatory challenges, if I look at the FDA versus CMS, I think more of them at CMS and Medicare and Medicaid than there at the FDA today.
Yeah.
I wouldn't have said that 10 years ago.
Yeah.
I think on the legal regulatory side, I think there's challenges for sure. Telehealth, if you could get rid of, we've got all these different fiefdoms built up around medical licensure.
Yep.
So every state's got its own licensure.
Yep.
One of the things that CMS did during the pandemic
Yep.
was allowed us to have telehealth across states,
that's right.
which is a huge plus.
Yeah.
Opens up the doors, allows you to solve problems in a much better way. You're not so stuck on, well, in this state, there's only this many doctors.
We have to virtualize innovation, expertise, licensure. Absolutely.
More and more of that.
More and more, yeah.
It's like the old days, like Nighthawk Radiology, which goes back 15, 20 years now, that solved a problem of rural healthcare not having radiologists on staff. They just couldn't have them, so they're able to read virtually, read from a distance, and stuff like that. And we need
Yeah.
to sort of ultimately make healthcare much more like that throughout.
So how do we get it done? Like you need some evidence and then a good lobbyist and a silver tongue and go to K Street and like
I think it's a lot of that, and it's a lot of aligning interest around it.
Yeah.
So even with telehealth, this fascinating situation. We all want telehealth,
Yep.
and at the same time, there are still some holdouts that are amongst the most established people in healthcare that don't want the competition from Seattle. They don't want the competition from Silicon Valley.
Right,
They just
right.
don't want it.
Yeah.
They want to make sure, yes, we could have telehealth, but we need local doctors doing the telehealth.
yeah.
And they've got an ear in Washington for a couple different reasons. Many of the health systems that are so important to our country they're the biggest employer in their local communities.
Yeah.
So the congressmen, the congresswomen are very receptive to whatever the local health system says. And health systems are of two minds in this. They want telehealth fully, but many of them don't want telehealth from out of state.
Yeah.
Like they want telehealth, they want their doctor to be able to provide telehealth, but they want to still be the first call of their physician.
Yeah.
The first call of the patient, the first call of the patient.
Yeah.
So not really looking to have the first call go to somebody that shows up first on Google
Yeah.
and be Amazon.
Yeah.
And so you have these very complex, different competing interests on it.
Yeah. What about medical tourism? The fact that if you look at centers of excellence, you have places in Bangkok and South Africa
No.
and Dubai and Abu Dhabi and Where is that going to go?
Well, I think you're still going to see great resistance to Americans going overseas for care.
Yep.
I just think it's at the end of the day, like if you had a need to be done, or and you can get your knee done in Chicago, Ross, Northwestern, North Shore, Advocate. If you really want to go to Cleveland Clinic, you can go. You can go to wherever you want to go. You're probably not to save X amount of dollars going to India to do it. I mean, you're just not, even if it's a third of the price.
They try to package it with a, go have your face done and then go on the beach, and it's
I don't
kind
think
of
you're doing
marketing.
that. People are still like trying to recover. They're still trying to get better.
Yeah.
I mean, if anything, if you look at hospital and home, it's proven if anything, people would rather be at home for the recovery. They certainly don't want to be like, if I get COVID, I don't want to be overseas. I want to be where I know I've got resources, where I know I can be taken care of, where even if I know they have great health care, I don't know that I'll have access to the system. Whereas if I'm here, I feel like I have a better chance of getting the access I need and where I want. You do still have medical tourism, still a huge business of us trying to bring medical dollars here. And so for some of the biggest institutions in the country, Cleveland Clinic, Ross in Chicago, Northwestern, it's still UCLA, bringing in overseas dollars to here from wealthy people overseas is still a big, big deal.
Yeah, you see
within
that a lot
the United
with those
States.
brands.
People don't really like to travel. I mean, you still have people that go to we had
We only have 11% passports in the United States or something.
that might be what it is.
Yeah.
I don't know if it's that low number.
Yeah.
But they don't even like to travel. They don't like to travel even within the U.S.
Yeah.
When you find somebody periodically that still runs up to Mayo Clinic, so they've got a difficult diagnosis. I mean, you still see that.
Yeah.
But it's not like a generation ago, like 30, 40, 50 years ago, when my grandma had cancer, everybody went up to Mayo Clinic. That's what they did.
Yeah.
Now, more and more, they stay here, and once in a while, you've got somebody, they've got a very complicated problem, so they're going to Mayo Clinic, they're going to Cleveland Clinic, they're going to wherever they're going. But I don't think, Walmart might try and force their employees to go to a center of excellence, but it's likely to be a center of excellence within 100 miles.
Yeah. Is there, if you think about different models, like Kaiser's moved the needle quite a bit, right, over the last decade. 10 years ago, their brand, people would say Kaiser, and now if you do your homework, they have some pretty wicked outcomes, right? They have great outcomes for a lot of shoppable, and they've driven a lot of traffic, and it's not as closed, and you know, is there opportunity for different models? Like I talked to somebody one time that said, healthcare we need a Best Buy and a Sam's and a Bed Bath & Beyond. We need chunky that get to scale and efficiency and standardization more. Man, talk about hard.
No, but I think your point, Kaiser is this fascinating example. So if you went back 20 years ago, very similar to the evolution of some other health systems. Some doctors would have said, I'd never practice at a Kaiser hospital, it's second tier. Yeah. Then about 10 years ago, I was on a panel with the CEO of USC. And this was to me, the linchpin of the change and pivot for Kaiser. It might have been 10, 15 years ago. And the CEO of USC said, we are now losing, most of our residents are going to work for Kaiser.
Yeah.
And Kaiser was paying them well.
In my community, they all went to work for Kaiser.
Yes. And so what happens is Kaiser made a transformation into a high quality, efficient system. They were, of course, on a value-based system. And so early on, before the pandemic, they had moved towards, famously, 60% virtual visits of somehow or another. This was before the pandemic because it made sense for them because they were paid to manage care and keep costs down. So it's just more efficient than bricks and mortar, everybody coming out. The idea of a system, and I'm obviously a fan of this, where you're not necessarily one system fits all, but you're working towards innovation and trying to figure out what works is, I think, a great working premise. I mean, I think it's a great working premise. Ideally with some baselines that, yes, you could work on whatever you want per state, per whatever, but there's probably some baselines of care that we have to have. And I do think ultimately, it's not that we need to get to universal care and how everybody gets the same care, but we do need to get to a spot where everybody is covered, where we've still got 10% of the country not covered. We have to get to a spot somehow or another where that last 10% is covered, because I think we'll find, both from a humanitarian reason, but from an economic reason for the country, that 10% of people probably cost us a ton more on the back end than it would if we just took care of them in a preventive way on the front end.
Back to your point about prevention, right? If you wrote checks and invested directly in some of their challenges, they wouldn't be in the ER.
100%.
Yeah.
If we had a preventive medicine for that last 10%, it's like last mile delivery type logistics. If we took care of that 10%, we'd probably, if we did it in an intelligent, efficient way, a rational way, any kind of rational way, we'd probably save more than we're spending in ER bills and in also human suffering that we have now. Because people, you're not going to the ER if you don't have healthcare coverage until you absolutely have to. It's embarrassing amongst all other things.
Yeah.
You say, I don't have coverage. I don't have coverage. I'm here. I don't have coverage. You get looked at differently. You get talked to differently. You get treated differently.
Yeah.
So at some point, the sooner the better, we solve this issue. Unfortunately, this issue of getting coverage for everybody, and I'm not a fan of Medicare for all. Coverage for everybody doesn't mean Medicare for all. It means somehow or another, through Medicaid, through exchanges, through picking some of these people up on Medicare, whatever it is.
Yeah.
I'm not advocating Medicare for all. I am advocating we get that last 9% covered, and I think it's just necessary on a multiple different reasons.
Yeah, yeah. What's the whole of our conversation is like, what's the tipping point in your mind? Because we all know this is reaching a point where it's not sustainable, right?
Yeah.
There's imbalances, and it doesn't feel like it's quite there yet. Like our back's truly against the wall.
Yeah.
When is it?
Well, I think we're getting close. What happens with people is, one of the things that happens in a country as big as we are is, there's an old saying, a recession is when the economy is moving in the wrong direction. A depression is when I lose my job.
Yeah.
It's a saying. I think what happens is we're moving towards a spot where anybody you talk to in a poor or wealthy community, whatever color, whatever ethnic group, people talk about challenges in accessing a primary care physician, and there are big challenges, but they are solvable in a lot of ways.
Yeah.
When you talk about accessing a specialist, depending on what community you're in. In New York City, it may be easier than it is in Chicago. It may be easier in Chicago than it is in, Duluth, Minnesota. But you're getting to a spot where everybody knows if you have to access the right specialist, you need to know somebody.
Yeah.
And that's a horrendous system.
Yeah.
Like that part of the system is absolutely horrendous. That you can't get to X, Y, Z specialist without knowing somebody to know somebody to get through.
Yeah. There's still so many layers.
Yes. And as all of us, it's the recession depression comment. As the mainstream of our country gets clarity that we have these horrible shortages, that's not just affecting others, it's affecting them, is when people start to say, we got to solve these problems. Right now, we're in this horrible situation in that Medicare for all, and I'm not a Medicare for all fan, I am a coverage for all person.
Yeah, sure.
Believe in coverage for all.
Right.
Coverage is the first part of the problem, then we've got to get access for everything. And access and coverage are two very different things. They're two completely different things.
That's right.
But what happens is right now we're in this horrible situation where every campaign cycle, coverage for all becomes a hot issue.
Yeah.
You have senators talking about it. On one side, it's a big campaign issue, and then literally, this was the quickest time, the speed of light, from when it moved from we've got that is a campaign issue that everybody's excited about to it's not talked about at all.
Yeah.
And we need to solve that coverage issue. Then we've got to figure out access.
Yeah.
And they're two very different issues.
Absolutely.
And we got to be working on both of them.
Yeah.
But we got to solve coverage because it's only 9-10%.
I feel like we need a better vocabulary because the current lexicon for this stuff, to your point, it just creates division and
yes,
people get polarized. But if you talk about it in a more brass tacks way, and then educate people the difference between those things, and
what you just said is, I think, 100% correct. This concept of we need to move from this being a political issue to being a problem-solving issue.
Yeah.
It's almost like end-of-life care costs this. How do we solve that? How do we fix it in a humane way? How do we fix 10% of the people don't have coverage? This isn't going to cost you, Mr. Taxpayer, you, Mrs. Taxpayer, more. This is actually, if we do it right, and it's not even like, it's costing us so much now, and somebody's paying it. We're all paying for it, we're just paying for it in a very inefficient way.
Exactly.
But the more we treat it as a problem-solving issue, what happens is on the right, you'll periodically have people say it should just be a free market. And of course, it's like the campaign signs 4 years ago, get government out of my Medicare.
Yeah.
I mean, it doesn't make any sense.
Yeah.
Medicare is government.
Yeah, right.
And it's not,
Right.
we're already 50-60%
Right.
government paid. So the right on it's not right, and the left just yells at the right about it.
Yeah.
It just yells at people about it. And we need to get out of that way of doing business to a way of We have to solve a problem. We got to get coverage for everybody. I mean,
Exactly.
And getting the way they're getting coverage now, it just doesn't work, and it's expensive, and it's not healthy.
Yeah.
And so we need to move towards how are we solving problems, not how am I yelling at you and how are you yelling at me, but how are we solving a problem?
Yeah.
And we need people on the right and left to agree that we got to move towards problem solving.
Yeah, there's always common ground, especially when you make
Huge
it
amount.
common sense, right? Let's not make it a political issue. But a lot of times they have to see the math. I find that the
Yes.
people that take a strong position don't spend time thinking about the math, right? And the return.
We used to say, the worst people are people that are confident and stupid. Confident and stupid, and I say that jokingly. I know it's
Yeah.
offensive, but the concept is people that talk so confidently about an issue without studying the issue at all.
Right.
And you see this, of course, in multitudes on
What
the
they call
right
that
and the left.
unconscious incompetence.
Yes, yes.
Yeah.
But
Yeah.
literally confident about your position with no insight about it. And it's not
Yeah.
that there's no, I'm a huge believer, I'm closer to Elon Musk as an absolutist on free speech.
Yeah.
So once we start governing some free speech, we don't know what we're governing and who's going to choose what's right and what's wrong.
Right.
But you have right now people that talk so diligently and so strongly without any studying or effort to sort of understand. And I do think just that sort of getting back to how are we problem solving versus fighting is a huge difference.
That's where we need innovation and intellectual debate.
Yes.
So let me ask you this. You're Scott Becker, right? And you have a voice and a good platform. I've been asking a lot of our guests, go out to 2025, and what do you want to get done? What do you want to leave your mark on by something like 2025?
Yeah, and I would say less about what I want to do. What I want to see, if I had a couple sort of big bullets that I had to use, they would be fixing medical education in our country so we could produce more doctors, more nurses in a much more efficient way. I think we all know it's a problem. It truly is a problem solving, not a left versus right issue.
Yeah.
So how do we produce a ton more doctors and nurses and make it a lot easier?
Yeah.
It's not that you're going to spend 2 years to become a doctor, but right now it's 4 years of medical school, 4 years of residency, 1 to 2 years of fellowship. It's literally a 10-year education after undergraduates. People are 30, 32 until they become doctors. And nurses is the same thing. We've got what should be a very attractive profession, and we've made the hurdles for all kinds of territorial reasons, all kinds of archaic reasons, way too hard. So the one thing I'd want to do is seriously fix medical education.
Yeah.
I think I'm not one that says the U.S. healthcare system is broken. I don't think it's broken. I think it's remarkable overall, but challenges. The education system's not broken, but it needs a knife put to it. It needs literally, we've got 2 years out of becoming a doctor, a year out of becoming a nurse, and we'd probably be fine. We need to educate right. There's much more efficient ways to educate, but the old method is just create so much debt, we don't have enough residencies, and we're leaving ourselves with horrible shortages of doctors and nurses and everybody else throughout the system. So that's one. The second thing I'd love to fix is ultimately coverage, to figure out a way to, I was when Obamacare was passed, I was not necessarily a fan of it. 10 years later, I'm a fan of it. I'm not necessarily a fan of that method of doing it, but at the end of the day, if the fact that we've gone from 20% uninsured to 10% uninsured is just a critical segue we needed to have, right or wrong, on how it was done. And he did probably the art of the doable and how he did it. And again, 70-80% of those newly covered people are on Medicaid. Another 20% are other ways. But one way or another, we've got to get to a spot where we can get to coverage for all, so we can all spend our time figuring out access for all.
Yeah.
And so that's sort of what I see. The two big things I see: medical education and coverage, getting coverage for everybody, and then figuring out from there, how do we improve access for everybody? And a lot of it's innovation, some of the things you're talking about.
You when you mentioned that, it made me think of, I was recently reading an article about new collar. We have blue collar, white collar, and new collar is this notion that you don't have to go to a 4-year degree. There's a lot of jobs, right? Even like a data scientist, folks we hire a lot. You can become a really, really good data scientist in 2 years, right? Using modern tech and modern tools to do it in virtual classrooms and much more affordable, marketable skills. And it makes me think that, to your point about even medicine,
oh my God,
why not?
Yes.
Right?
You don't need 12 years of memory anymore.
Yeah, yeah.
You need to be very good at processing
That's
stuff.
right.
You need enough training to really understand things, to recognize things, to get good at them. And so there's so much of that. But this new collar thing, it runs counter, which is, you're exactly right, but it runs counter to so much of where our community has gone, where every kid is entitled to a 4-year college, every
Right.
kid's entitled to every kid, even though we know it's leading them on a road to nowhere for so many kids. It's
right.
at the end of the day, they have these great studies and they publish them all the time.
Yeah.
Person spent $300,000 on graduate education and they're making far less than they would have made in some kind of other type of trade or business or job or whatever it is.
Yeah.
I mean, and they're out of whack. So they've got debt that's horrible versus their job. It's a horrible situation. It's a sort of like, we had a great speech by a speaker years ago about the 3 things people pay for over their decades are retirement, their house, and now it's their college. And
Yeah.
it's incredibly horribly stupid situation we've all put ourselves in.
Yeah.
You know, you've developed this education industrial complex that is crazy out of whack with what it produces and what's useful for our long-term citizenry.
And the write-offs that are happening right now, it's kind of like you're going to spend the money one way or the other, right? It's kinda
100%.
like, so I think that there's just massive, because a lot of kids want to be productive faster.
Yes.
They know that they could
Yeah.
tackle that job with 2 years and they don't have to go to a Ivy League brick and mortar.
It's become such a complicated system. It's a complicated set of questions,
Yeah.
and it's one of the reasons why it's so complicated. It goes to this concept of haves, have-nots, privilege, not privilege, stuff like that. And if you start saying not everybody needs colleges, if you're not privileged, you figure what they really mean is I'm not getting college, but all those rich kids are getting college.
Yeah.
So it's a complicated thing to try and figure out the right answer and how we work through it. You know, and what, you know, and it's a real challenging situation because, for many kids in college, it's become an entitlement. And for wealthier kids, it's become 4 years of advanced camp.
Yeah,
and for other kids that are working hard, it's become a really useful thing. And it's a real mix as to what the kids make out of it and what they do with it. It's a very complicated situation in our education system today, but it's one that's left people with a ton of debt. And I'm not a believer that everybody gets write-offs of their debt. They pay their debt, but it's a very complicated set of questions.
Yeah. No, it does seem like you're just an amazing, you say medical education, and that got me thinking, like, I've been recently studying broader education, but those lessons learned, could a doctor, in less than 4 years, and less than 4 years, and less than 4 years? Yeah, he could.
100%.
Everybody knows. And why not have the brands, the big box brands, become digital brands? Sure, you can go to Princeton and Harvard on campus for certain things, and I know they're doing this, but I think it should be much more pervasive.
Yes.
Everybody should be able to get out your credit card and say, I just took 6 weeks of that, and it's a Princeton course.
It would be
Harvard
phenomenal.
Business Review's doing some of that. Because it's all about jobs to be done at the end of the day. We're big on, if you break things down into jobs to be done, then you take away the gravity and the emotionalism, right? That's how I feel like we got to get Washington and all the big lobbying groups, like, let's just focus on what's got to get done, and best idea wins,
But I think your point is that at the end of the day, and there's more and more talk about this, that medical education, all education, a lot of education, aside from being this broad liberal arts and learning how to think, read, write, so forth, this concept of outcomes-based education. Like, what does a doctor really need to know at what age to get out and practice? And what do they really need to know versus we're keeping him or her here 4 years of med school, 4 years of residency, and then a couple more years, versus what do they really need to know?
And, IBM Watson is, we could probably end on this, right? I always say IBM Watson was the right idea. It was an execution problem. Because Watson did beat a human being at Jeopardy, right?
Yes.
And it could be used to help the doctor be his brain, right? I think we'll have to leave it there, right? Because our team is telling us, I could talk to you all day, right?
And myself to you.
Yeah.
A total
No, I just want
pleasure.
to thank you again, Scott.
Thank you.
Really appreciate this, and this is a fun new format. Thanks for helping us come up with the idea.
Well, we're thrilled you're here.
And we'll be here, for the rest of the week, and then back in the fall.
God bless you. Thank you so much. What a pleasure.
Thank you. Yeah, I really appreciate it.
Thank you.